address. If there's a parent or guardian for a minor, it must be listed. Just keep in mind that we also verify, it's your responsibility to verify you have the correct patient in the chair. And we usually do that by name, and we'll ask a patient what their birth month and date is. We don't say year, because if name and birth month and day are accurate, you can be pretty certain you've got the correct patient. Purpose of the dental record is a permanent record. It's there forever, whether it's a paper one or a computerized one. Assists in patient care. It protects the practitioner, in a legal suit. Acts as a tool in defense of malpractice, right? If it's not documented and dated and in some way signed somewhere on the form, it's considered that it didn't happen. It doesn't matter how conscientious and how hard you work as a hygienist, you're not protecting yourself if you don't document. There can be no blanks. This is huge. It's huge for legal reasons, because if you leave blanks and then every so often a blank is filled in and you go to court, they're going to say, we don't know if you filled this in after the fact or that day, or we don't know if you asked the question because you left it blank instead of putting none or NA. It looks like you never asked the patient if they have, a dentist, or if they have a patient or a dental concern. Maybe you left that blank. So you have to be careful. Absolutely no blanks on medical history, oral exam, things like that. When you document your procedures rendered, you will start your next entry on the very next line. You don't skip lines between entries on paper documents. Now, fortunately, things are going electronic, so that eliminates some of that stress. But, for us, because we can't get on the Dover Air Force Base records for the patient, we will document a paper chart for Deltec. We're not able to do to download a program for you guys to use that will be that. I mean, we could do it on a laptop, but it's not going to keep the patient record. We need the paper chart so we can always have a record to refer to. Formats and protocols should be outlined and followed by all. So you're going to find there are some protocols that the military uses. There's some abbreviations that Deltec uses, and we don't stray from that. I'm trying to think of an example. So for Deltec, we would put FL for fluoride, but when you see it in the Dover Air Force Base records, if it's pre-stamped or whatnot, it's going to say F, or it's going to say the whole word fluoride. They don't use FL. So what this is trying to say is that you're going to work at multiple offices, multiple whatever sites, and you need to learn what that facility, what that office, whatnot uses, so that when another person reads your documents, they can understand your abbreviations, because they're universal for your workplace. If you use an abbreviation and nobody understands what you're trying to say, you have let patient care become compromised, because you've documented and nobody knows what you're saying. Staff must use similar abbreviations, and that's what that's saying. Like CR charting means caries restorative. MH means medical history. But there are some that aren't universal, like those that are office specific. And if any of you guys worked in multiple offices, you could probably think of one or two that you've had to learn or remember to use, use it a different way than you're used to writing. And I mean, you would think this goes without saying, but you must record all facts pertinent to the patient's history, exam, diagnosis, visits. But what you have to remember, when the dentist sits down to do the exam, typically at the end of the prophy. If you've had your teeth cleaned, they'll pop in after the x-rays are done, the prophy's mostly done or has been completed, and do the exam. And if the dentist says you're getting little areas that are pitted, he's not going to say incipiencies because a patient doesn't understand that. You're getting some pitted enamel, early caries that don't, that could be reversed. You need to rinse with fluoride every day. It's your job as a hygienist who's in the room with the dentist to write that in the chart. So it's not just what happened that day, oral exam, treatment plan, polish, fluoride. It's also other things that are discussed, or the dentist may say, or the patient may say, I do not want x-rays that day. I can't afford it, or I don't want the radiation. I just have a chest x-ray. We're going to have to postpone this for me to feel comfortable. It has to be written in there, and the patient has to in some way sign it and date it. There's all kinds of little things that happen in an appointment that you have to constantly think, I have to write this down. All entries in the patient record must be legible. So if you struggle to write neatly, you need to slow it down. You need to put clear, maybe start practicing at home now, clear documentation. It's very important that you use non-erasable ink, because if in any way you could have altered a document, you have just taken away any credibility you have that you have a legal document that's not been altered. Your documents must be unable to be altered. In other words, you could put a line through it, which we're going to talk about, and because you made a mistake, but you can't erase something after the fact, because you're going to alter the document. That's why when you have a record for a patient that's electronic, you can type and, I have some typos, and you go back and change, tidy it up. But once you hit save, that document cannot be altered, or if the program's set up correctly, should not be able to be altered. It can be added to with an addendum, little comments, but you should not be able to alter that document in order for it to be legally binding. Patient's first name and last name must be on the chart, not just Jen. It has to be the whole name to be clear. Whose chart does this belong to? Your first initial and last name must be on every chart. And the information should be sufficient to recreate the event. So if a patient's getting quad scalings and you see them for 2 visits, but then you're on vacation and they come in for visit 3, upper left quad, the hygienist knows this patient needs topical. They have had desensitizing on several teeth on the right side, so I should anticipate it and be ready for it today. I need to look at the x-rays because there's radiographic calc, not just, clinical calc, but some of it's so deep that I need to review my radiographs to be sure I'm not tapping on top of it, but getting underneath it. So there's a lot of information that you need to document so that the next person who comes behind you can recreate exactly what went on at your appointment. Clear, concise. So we need a lot of information, but we don't want to ramble on. We don't want extra words that don't mean anything. If a patient needs to pre-medicate, which doesn't happen as much anymore, it used to be much more common when we would pre-medicate for mitral valve prolapse and for knee and hip replacements 10, 20 years after they've had them. That's not as common. But if a patient is supposed to pre-medicate and, you sit them down, how you doing? Did you take your pre-medication for our appointment? When you go to document your records, you need to note patient states that they took, 2 milligrams or 2 grams of amoxicillin prior to 1 hour prior to appointment, Not that you, because if you didn't see them take it, it's not accurate to say patient took. Patient states that they took, you know, the pre-medication, the amount, and the time also needs to be documented. So that's how concise, how much clear data needs to be there. Comprehensive and complete, accurate, consistent, legible again, dated, and signed. Absolutely no whiteout can happen. If you have to change a document, you draw one single line through it and you write your initials. And then if you caught the error immediately after doing it, like is depicted here in the sample, 2 carps, which means carpules of lidocaine, and SRS was the person who made the error, so they put their initials in parentheses. And then they wrote what they meant, 3 carpules of lidocaine. Do you see how we did not put a slash or a line through 2 and write 3 above it? That's not acceptable. So the whole entry had to be crossed out, initial it, and then write what you mean. But most of the time what happens is we write along, we do our paragraph form of documentation, and then we reread it and see the error. And you will have to put a note at the end of your document. You'll have to put the line through it, initial, you know, off to the side of it, but then at the bottom you will have to put additional note, date it, and put what the comments are. So you can add to the patient record. A few days after patient treatment, you realize the record's not complete or was not recorded. It can be added and dated with a note stating that it was not included on the original date. It's not a once and done. You know, there are times when I've gone home and I'm on, you know, the day is calmed down. I'm driving my long drive home from work. I used to work an hour from home for years and years. And I'll like, oh shoot, I talked about that patient about Proxibrush while we waited for the dentist. And I forgot to go back and add that. So I'll, you know, I'll make a mental note to write down when I get home. And then I'll go back and add a dated entry on, you know, last visit, such and such date. I reviewed Proxibrush, this area, you know, and that is okay because we're not perfect. We're going to have, it's better, more important that you add the information, just as long as you don't try to add it and act like you already had it there. Entries made after several years are not considered consistent. You couldn't go back and do that. You guys can read through that. This is talking about your OE, type and number, patient ed, anesthetic, is it topical or local, where, what type, the amount, if it's local, was it half a carpule? Dentists will sometimes say half a carpule, or they'll actually write how many, you know, milliliters that carpule is, or cc's. Method of delivery, was it topical that was Orachix, delivered via the Orachix dispenser, or is it topical applied with a cotton swab? You guys can read through this again. Oral irrigation, where, the type of solution used is what they're talking about here, the amount, and the method of delivery. There's a oral irrigation that can hook to a unit and be consistent delivery, so it would have a brand name of that type of delivery, or it could be, you know, a little syringe irrigant. So you can see there's a consistent theme. If there's a product used, you always have to say where, what, you know, what type, and if there's several methods available, what method. Sealants can be auto-cured, they can be self-cured, they can need acid etch, Some are self-fetched. So there's different products. This is part of being concise and clear. And, you know, as you learn each product, we'll discuss these in lab, what the different options are, so you become to understand it. Just know that there are different methods, different types, different brands, and you have to know. So fluoride therapy, type, length of time, method, and maintenance protocols. We call it continuing care because you see patients multiple times for a prophy. Remember we said when you go to the dentist or I go to the dentist, my appointment takes maybe 45 minutes to 55, according to what office I'm at. And I'm done, right? So I'll go to the front and they'll say, okay, your recall appointment is 6 months from now. But we use recall to mean like the next, you know, we'll say next visit for if we're continuing care. It'll say next visit, scale right left side, you know, reeval previous treatment, scale left side, and maybe polish at that point. And then we'll say continuing care, and that's used instead of the word recall. And you write the month and the year. You also need to note, you know, no-shows, cancellations, but patients late. Trust me, there are patients who will every appointment arrive 15 minutes late. And you need to know that because that's going to affect the patient after them quality of care. So there, you know, there could be a time when a patient, they might, you know, if they're so late, they might have to be turned away, and hopefully your front desk will do that. But you need to document if this is a habitually late patient, because if it's not good for your practice, and it's not good for the patients who are appointed after them, and it's every single time, you know, or they don't show 3 times before, you know, it takes 3 times just of scheduling them an appointment before they'll show. This has to be documented, or they cancel day of repeatedly. Warnings, you know, advice, instructions, recommendations, referrals. If you tell a patient, I'm seeing a lot of bleeding and puffy 5mm pockets, these are typically signs that you're susceptible to bone loss. I'm not seeing it radiographically yet, but it appears that you are prone to bone loss at this time. That must be documented. Okay. Test ordered, prescriptions written, products dispensed. Any letters, if a patient was sent a letter, you know, from the front desk stating a bill is due, that's going to be documented in the record somewhere. Any refusal of patient to accept treatment. We talked about radiographs. That's the most common one that we'll get. It's not real common, thankfully, because it's very helpful for the dentist and the hygienist to provide well-rounded quality care and not have a caries go undetected that can't be seen, but it happens. Any patient responses that are negative or positive made by the patient concerning their treatment, and professional response, if any. The right to privacy. This is the HIPAA. They have a right to confidentiality regarding their condition and the care they receive. The healthcare provider must ensure that patient records are not visible to others. And let me give you an example of this. Back in 1994, TB surged its ugly little head, and somebody called the office and said, I had a bad cough for a couple weeks, finally went to the doctor, and I have TB, I'm being treated. I was in your office during that time before I found out that's what's going on. So of course, all of us in the office trucked our little selves out to get tested. And I had a positive TB time for the first time ever. Now, back then it was called TB time. Now it's called, I forget. I can't even remember right this second. But you guys all had the same test. It's just different, called something different. And so I had to go to the Delaware Public Health, because at the time, I don't know if that's still how it is, they were the ones who took you under their wing, gave you all of your protocols, and referred you for your x-rays or for your chest x-ray, did the sputum test. You know, your physician could do it, but the physicians at that time, because of this resurgence of it, were referring to public health so that data could be collected. So I trucked myself on over to public health to see what I need to do. Luckily, all my tests came back negative. I did have to do some INH therapy as a precaution, which is a pill every day. If somebody truly has TB, they're on like 3 or 4 pills a day to combat it. Antiviral, antimicrobial, this, that, and the other. So anyway, I go into the gal's office. Keep in mind, this is 1994. Everything is paper chart. And she's an overworked soul, like the rest of us in healthcare, no matter what decade you're talking about. And all of her records are sitting on her desk, and they're not stacked tightly. The names aren't turned away from me at her door, where I'm standing at her door. And not being nosy, I just, look down, look around like you tend to do. I can see 10 patients' names right there. We're in Dover. It was very small, not like it is today. You knew, like everybody kind of knew somebody who knows somebody. Everybody knew everybody back then. 80s, 90s. It was much less densely populated. Well, there's my patient's name, who I should not have been privy to. When I was told by the front desk person, I was not given a patient name because it was not my, I didn't need to know that. What I needed to know is I had had an exposure. The patient's HIPAA rights, even before 1996, we were practicing HIPAA. It just wasn't the clear documentation that's held up in court as it is today. We were not sharing patient names unless it was critical to the patient's care or to our knowledge. So I should not have been able to see 8 patients in the Dover area that was being treated for TB. And I certainly didn't want my record there, because you don't know what they're being treated for, but they're at public health for some communicable disease. You just have to understand, nobody has any right to this information, and it's critical. When I see patients in an office, and I think I said this to you in 111 when we had a conversation about patient rights, I'll have a patient who'll come in and say, oh, I'm so-and-so, whatever. I'll look at their occupation. They happen to have the same job my husband has. I'm like, oh, you might know my husband, this, that, or the other. We'll have a little conversation. If I don't remember to ask that patient, are you okay if I tell Mike, my husband, that I saw you today? I do not go home and tell Mike that I saw that patient today. It's that rigid of a rule. That they were even at the dentist is nobody's business. So you have to be careful to not take it too lax. Do you have a question, Melissa?
I was going to share a story about something that happened like here.
Yeah.
About that. It was a friend of mine who came here as a patient, and then someone said to her mom that she was here for an appointment, and her mom didn't know at that point that she was pregnant, and it was like a whole big drama. And I was like, something so like little that you just say to someone, and then it just and it's not supposed to happen, and it happens here, and I'm like, we could get in big trouble.
We're privy to more information, even being in the little dental field, than the general public. Even spouses, unless the patient says, yes, you can share all my information with my spouse as needed, you cannot tell a husband that a wife needs a filling, needs a restoration. It's that cut and dry. The patient
Yeah.
information stays with the patient and you and the dentist and insurance, if they're part of it, just what the insurance company needs to know to do their job and nothing more. So
Yeah,
you
we get
have
training
to
for
be
HIPAA
careful.
every year.
Yeah,
We have to do it every year.
it's huge. If a patient was so savvy enough and they had, you know, financially able to pay for a lawyer, or got a lawyer got hold of them and said, I could make you some money here, you're in deep doo-doo, because
Yeah.
HIPAA is clear cut.
Yes.
So you have to be very careful, but you could also just ruin a patient's, you know, I mean, I'm sure that patient wanted that to be her business until she was ready.
Yeah.
Emotionally disturb that patient.
Yeah. It
And
was
it's
bad.
all innocent, you know, it's very innocent because you feel excited. This patient has this life-changing moment and you're excited for them, but you have to rein it in.
Yeah.
It's easy, right? It's so easy.
Yeah, because she was a nurse here, and they all
Yeah.
went to the same church.
Yeah.
So that's how it happened, and yeah, and she got in trouble.
Right, because you would assume mom already knows, but he
Yeah.
might not be the case. Husband might not even know yet, or boyfriend or whatever.
Right.
It's very easy. Loose lips sink ships,
Yes.
but it's very easy, unfortunately, and that's where we all get in trouble. So I just had to stop on that because it's huge, and I don't want to like flip through that for 2 seconds per slide, and you'd be like, ah, it's just another thing to know. It's a huge thing to understand how important it is. So this goes on to explain that. Presence of non-essential persons. So only personnel contributing to the performance of healthcare services should be present in the treatment room. Specific permission must be obtained from the patient before non-essential persons are admitted. And this happened for each and every one of you, or it should have happened when if you weren't a dental assistant, when you asked to observe in a dental office to get your dental observation form signed off for your dental hygiene application to the program. They had to ask that patient, could you stand and watch this dental procedure? Do you mind if this person watches this prophy today? Because they had a right to know that that was an option to them. You didn't need to be there for their care that day, and it was a request being made. So that is one example of non-essential persons in the room. And you guys are aware of this, you know, you may not remember it. There were so many forms you had to fill out at your fall orientation, but one of the forms you filled out was signing that if a picture was taken of you in a Deltec setting, and they wouldn't take a picture, you would see the person with the camera. I mean, they would make it very clear pictures are being taken today. But you are signing that it's okay to have your likeness and even your name posted with Deltec on a picture. And you've seen some of those pictures when you log on to My DTCC. There's our dean of instruction, dean of student affairs. She's on one with some students in a courtyard who are at a lunch table or a picnic table, that type of thing. But if you use anything of the patient's, we have to have written permission. And a patient's name or other identifying information must be removed when using records for professional presentations. So I hope you get to see the oral health counseling, even if it's recorded and you watch it, not the oral health counseling, the patient presentations that 205 students do at the end of the semester. But you're going to see, or when you go to do yours next year, all the patient information will be removed. And occasionally a student will show a picture with the patient. They had to get a written document signed and put in the patient's file, signed and dated by the patient in order to do that. So this will affect you if you choose to use a patient's picture or would like to, of their face and likeness. but we still will not put any name or identifying information other than that. So this is HIPAA. It first became effective in 2003. So it was an act in 1996, but it became, oops, sorry. I got very clicky. There we go. It became effective. Like it could be presented in court in 2003. But it, as I say, in the I graduated in 1986, right? That was like eons ago. These rules that are under HIPAA were beat into us back then, not literally, figuratively, as being critical and important, and nobody should know, what's going on unless the patient says it's okay. The spouse has no need to know this information unless the the wife or the husband that's your patient is incorporating them in their treatment, in their care. So this is not new. It's just because it's been revised and recontoured and become re-envisioned as a much more current, updated law in 2003. And so it's kind of the same. A patient can ask for restrictions. And you guys are aware of this because as a student, you can choose to have your student record restricted when you came to school when you were 18, 19, and 20. You did not have to have your parents able to see any of your student finances or records. A lot of students choose to allow parents to have, call financial aid and say, so-and-so is my child. And if it's on there that it's not a restricted record and the parent is, part of that process, because a lot of times the patients are helping out financially, but you already have a form of this as a student, your right to privacy. It's just not the medical version. This talks about changes. We have to keep abreast because there are always ongoing changes that can be finalized and written into law. And it just goes on. You guys can read that. Sorry, my big cat came in and he's a big baby. So the healthcare provider agrees or refuses ethical mandate to provide care when needed. As an RDH, we have the ethical, moral, and legal responsibility to provide oral care for all patients without discrimination. Legal requirement to accept patients. Exceptions include government-funded program with eligibility criteria stipulations. So some offices will take the Medicare, Medicaid patients and some will not. They have the right to accept those restrictions of fees or not. Provider contracted to provide care for patients enrolled in prepaid programs. Sorry, again. The monster off. Courts recognize the relationship between the healthcare provider and the patient as a contract. There's an agreement or promise between two parties. What is a contract? It's an agreement, right? Consideration is an exchange of something of value between two people. You guys can read that. It's pretty straightforward. When a contract exists, it means that both the healthcare provider and patient are promising to meet responsibilities. Certain warranties or duties are required by both the healthcare provider and the patient. You know, and as a medical professional, what's the first thing in our profession, right? Our symbol, do no harm, do no harm. So when a patient comes in and sits down in any medical professional, including dental, they expect that we're going to do the best quality care, because that's what our training entails, that we have been trained to do high quality, necessary care, no unnecessary care, and that we are not going to do anything that would harm the patient. Doesn't mean they may not have some ease of bleeding, some tenderness, or some sensitivity. It means the gingiva is not going to be lacerated, the attachment fibers aren't going to be, you know, displaced because of aggressive scaling or ultra scaling, those type of things. There is an assumption, a contract, even without it being stated, you know, every little thing, just from the medical do no harm as our motto. An obligation or responsibility is the duty which a person owes to another. So a patient comes in for an appointment, they schedule a specific type of an appointment, a prophy, a perio-quad scaling. They pay for that appointment. We have the duty to provide that care for that patient. So never exceed the scope of practice authorized by the license. So not all of you are going to be Delawareans for your whole entire life. And that's why no matter what state you go to, no matter if you've had a license for 3 years or 30 years, you move to a new state, you take a jurisprudence test. Usually it's open book, but it means that you are forced to read the rules of the state and answer each question, like a fill in the blank type thing, of each rule. So it's clear you were given the rules, you read the rules, and you correctly identified the rules, because they're different state to state. And local anesthesia not happening in Delaware for a dental hygienist is one of those clear-cut rules, right? We had a hygienist whose husband's military, and she moved to another state, and she's licensed for anesthesia, she's licensed for lasers, you know, all kinds of things. I have a hygiene friend who was trained to carve amalgam restorations and even place amalgam restorations as part of her state's, you know, expanded rules. California, Arizona, Nevada, they have a lot of expanded hygiene rules, so, or tasks that can be performed. So that's part of understanding what your limitations are. You might move, somebody might move from California to Delaware and think they can do this, that, and the other, and, you know, no, or to Maryland, or, you know, not just Delaware. There's lots of other places you're not going to do expanded hygiene care. You guys can read through that. That's pretty straightforward. Providing appropriate referrals and consultations. Always, always remember the patient's whole care is part of your prophy. When you know, I'm typically at my dental office 45 minutes to 50 minutes before I see patients when I work as a dental hygienist in an office, which I did full time for 8 years. And then I did every summer and during Christmas breaks for the past, whatever, 20 plus years. No matter how seasoned of a person I was, how long I worked in an office, I was always there early. I had my own personal stack of Post-it, you know, the 3x3 Post-it notes or bigger. And I had a note on every patient. This patient needs pre-med. This patient had a restoration a week ago. I need to ask, how's that feel? This patient was told they need a restoration. It hasn't been they haven't made the appointment, or they canceled the appointment. I had Post-it note on every single chart. This patient's due for an FMX, has refused it last 2 visits. I need to discuss that. This patient had an extraction. Dentist discussed 3-unit bridge. I need to help the dentist explain that to the patient. You'll be surprised how many times your dentist will explain a procedure to the patient. And because it's the first time the patient's hearing it, they'll go, okay, yep, and they'll leave like, oh my God, it costs this much and I need this done. And they're going to take 3 visits and oh my gosh. And then they come back a month later or whatever, they haven't scheduled it. If you ask them, I see the dentist discussed, that you need a 3-unit bridge. Do you understand, what that means? And do you have any questions for me? You will be surprised how much you can help that patient and your office communicate, what exactly this means. And they may feel more comfortable asking you as their every 6-month provider than they do the dentist, because they might feel embarrassed to tell the dentist he went through that whole spiel or she went through that whole spiel and they have no idea what they were talking about, right? They might feel embarrassed because they didn't ask then, and then they're like, oh, how do I tell them? I don't think I can afford it anyway, or I don't want to do it. But then when you start telling the patient without something to fill this void, 19 was extracted, there's a space between 20 and 18, it's likely that 18 will start to drift and tilt forward into that space. Number 3 is going to start to drop down, 14, drop down into the space because it has no consistent exercise. Your teeth are going to become out of alignment in this area. Then they're like, well, all right, I'll start saving money. I'll make payment plan. I'll talk to the front. Thank you for explaining that. Because it may have been explained, but people need to hear things more than once, many, many times. So that's part of providing appropriate, referrals, consultation, and following through with the treatment that a patient needs. Not just, oh, it's a prophy, let's do your prophy. Here's your x-rays, here's your fluoride, here's your prophy. There's a whole lot of things a patient needs that you can help out with. Termination of care. This is important to know. You have a right, the office has a right to terminate a patient's care under a limited aspect. You can't just not, this patient doesn't quite suit you that day. I'm not gonna call them back. I'll tell the front desk not to schedule them and then we won't call them for an appointment. You can't do that. But if a healthcare facility wishes to terminate a provider-patient relationship, certain steps are necessary to avoid the legal charge of abandonment. The health of the patient must never be jeopardized. What does that mean? That means that an endodontist can't start a endodontic procedure, put a temporary in and never, and then refer back to the dentist to do the crown. Like they'll finish the endodontic procedure. The dentist said you're going to need a crown or this tooth could crack. It had a large restoration to begin with, and now the nerve is removed, so it has no nourishment. This tooth is going to become brittle. You need a crown. So they can't be mid-procedure, follow through with the endodontist, come back to you for the crown, and you say, we're not going to do that. We're not going to see you anymore. You have abandoned the patient, and you could be legally, of course, that's the dentist I'm talking about, but there are things as a hygienist as well. I just want to give you an example how you could your office could be in lawsuit for abandonment. So the health of the patient must never be jeopardized. Written notification must be used and outlining all information for the patient. So you've seen this before, right? Maybe at one of your medical offices, it'll say, if you are late for an appointment, we have a right to reschedule you if it's past a certain amount of time. If you cancel an appointment, we have a right to charge you $35, $55, whatever for that time that was lost, another patient could have used. And if you cancel, 4 visits, three appointments in a 2-year period, we have a right to dismiss you. If your bill goes unpaid with a 6-month or a year period of time without resolution, we have a right to dismiss you. So there are like laws of the office that typically a patient will get and sign off on at some point. You're fairly young, so you may not have seen these documents yet, but they are out there. You're going to be see them from time to time, or you'll see a notice at the front desk when you go to schedule your next appointment, and it'll be there in writing for you to view. So the duties of the patient are kind of the reverse of that, right? There you have to pay within a reasonable time, provide accurate information. We had a patient who came to the dental clinic, a retired dependent female, and she gave us she checked all this random stuff on the medical history, couldn't give us any details about when or what year things happened. It was just it wasn't vague. It wasn't, it was just like she was just lying. So we couldn't get very far that day. And what we had to do was send the patient out for a medical consult to bring us back this information, because she wasn't able or willing or whatever to provide it. And we couldn't trust by her demeanor and the way she was providing essentially lack of information and misinformation that anything she was telling us was accurate. So they have to provide accurate information. So this goes in hand when a patient tells you and they need to be pre-medicate, or they need to have their medications on board for something. Patient states they took all antibiotics that were recommended for perio infection, and completed prescription as prescribed. Because you didn't watch them take every pill. But if they come back with a reinfection or a superbug because really they took 5 pills, felt better, and kept the other 7 for the next time they had a little sinus infection, they had a little backup med, you're covered, but you can't be responsible if a patient doesn't give you accurate information. So that's on the patient. Cooperate in their care. They have to keep appointments, follow home care instructions. You're going to help them get back to health by educating them what they need to do. Never say, I will make this better. I will help this improve along with your home care techniques we're going to review today. And this bleeding, swelling should improve, and we'll reassess next time. How are we doing on time? 1:53. We're almost done. Looks like we have 5 more slides. If you can hang in there, we'll be done for today, and then you can spend the rest of the time, because we're supposed to have a 2-hour class and a 1-hour seminar. So keep in mind that our classes are on Monday. This was a one-time only change to Wednesday. And 2 hours are for class time, but we do have a 1-hour seminar after that. So I'm going to wrap this up. I'm going to give you a 7-minute break, and we're going to do a mini toothbrushing and flossing review. So that will help you week 2 for your toothbrushing and flossing. And I'll tell you why. We have always sat in the conference room at the dental clinic, all 8 of you guys, the 2 lab instructors, on Friday, and went over brushing and flossing techniques. And then we would reconvene to a suite on the clinic floor, and then we would do with a plan for today. Go intraoral, practice the brushing, flossing demo on the patient as patient instruction, and have the patient and disclose the patient, would be part of that, and do the PHP, which is a patient hygiene performance index that uses disclosing. Well, now we can't sit all together in the conference room. So that's why we have to pull a few of these things out and put them where we can, where we already have a Zoom meeting scheduled. But it should only take about 15 minutes to go through toothbrush and floss, and we should be done fairly quickly. So I'm going to finish these slides and give you about a 7-minute break so I can bring up the toothbrush flossing and have that ready for when we reconvene in 7 minutes after that. Okay, so let's finish this. Classification of contract. It's implied, goes into effect the moment a professional opinion is stated. Opinion is stated, and when professional services are performed. So let's go back to professional opinion. Remember DHY 111, and I used a reference, I believe, where oil pulling, like people would put coconut oil in their mouth and swish with it for an hour, and it was supposed to cure everything. If you look on Pinterest, if you looked on, YouTube videos, whatever, they're all saying, oh, it's going to cure you can cure your cavity, you can cure your periodontal disease. Well, you can only restate what has been researched by an independent body. That means the Oral-B company or the Crest company can't come out and say our toothpaste fixes 99% of all bacteria in the mouth that causes gum disease. Because that's the Crest company, they're biased. It has to be an independent study. So you can't go, oh, my aunt uses that. She said her gum disease is cured. Yes, use it. It'll fix everything. You can't jump on anybody's bandwagon because you're a professional now. You have to only restate what is documented by an independent study. And then you can say, I have heard some people like that. If, I don't know that I haven't researched, has not showed any harm if you do that. And when you come back, if you choose to use that and try it, let me know and let's see how your gums look. I'll make good notes today and we'll see if that worked for you. But you cannot endorse anything that has not been documented as, as being true, right? Because what helps for one person is not going to help for everybody else, possibly. So you can't just because one person had a good result or whatever, maybe they were paying extra attention to their teeth and they finally started brushing twice a day, which they'd never done. You don't know what all things happen to make things better. So be careful. Professional opinion. That is implied that you're going to only state what's true and confirmed as your opinion when you're in a dental setting. And even when you're not, you have to be careful. And that your professional services are performed. Agreed to by the actions of the persons involved. In the example, during the patient's initial appointment, the medical history is reviewed, OE is performed, charting is completed, X-rays are exposed. There is no written document. The treatment plan has not yet been completed. These are all pre-procedures to assess what needs to go on the patient's treatment plan. It is an implied contract based on the performance of these services. Now, when you're going to take X-rays, obviously you will say, oh, you're due for your 4 bite wings today. Let's get those taken. And you have that opportunity to say, oh, I just had a whole head radiation because my sinuses are bothering me, and they took some, MRIs and some other type of images that were radiographic. I would like to do it next time, right? It's implied that you're going to do these things for the patient, but even though they're implied, they still have the right to decline something. Now, I have had patients, I have worked for hygiene friends in a dental office here, there, a time or two, and I have seen a dentist who will dismiss a patient because they refuse to get any X-rays at any time ever. and they're like, you know, they say to the patient, that is fine, that is your right, I understand, but it's my right to have the information I need to perform my duties, and I cannot treat you without that information. I think you need to find another dentist. And that you may in your lifetime have a patient dentist, you know, that are not feeling they meet each other's needs, and they will move on. Quasi-contract, one type of implied contract providing emergency care to an unconscious patient. So a quasi-contract, patient passes out, stops breathing, you perform CPR, right? You're providing emergency care to an unconscious, unresponsive patient. Express, one in which terms of the contract are outlined or expressed verbally or in writing. Expressed contract, a child comes in for their prophy that day. As their hygienist, I'll step into the waiting room and talk to mom, dad, or whoever the legal guardian is, and say, you know, Susie's due for her annual x-rays and her fluoride treatment today. And the mom will go, okay, or the dad will go, okay. Or, you know, say we choose to not do the fluoride and x-rays today. We'll have to do those next time. And sometimes it's due to money, right? Sometimes they just can't afford it. They have 3 kids. Let's get the prophy done. And at least an oral exam is better than nothing. At least we're not skipping the appointment. But that was, you know, that's just an example I have encountered myself, and you will too. So these are all the records. We've talked about those before. And keep in mind your hygiene manual, which you should have access to. I think I might need to repost that. Let me give myself another sticker. I need to repost that to your D2L, I believe, because you might not be able to see that manual. Okay, take a 7-minute break, set your phones for 6.5 minutes. I'll meet you back here in 7, and we'll do flossing and toothbrushing and wrap it up for today.